Welcome to my presentation on the narrow angle. I am Abraham Sir, a fellowship-trained glaucoma specialist practicing in San Luis Obispo, California. In this presentation, I provide a concise overview of narrow angles and how it relates to pupillary block angle closure. However, before you watch this presentation, I recommend viewing my YouTube talk on what is glaucoma. Anatomy and physiology are foundational to medical topics, so let's start there. The front of the eye within this circle is called the anterior chamber. Directly under the outline of the circle, where the color of the eye meets the white of the eye, is the angle of the eye. This graphic illustrates the anterior chamber and angle when looking at the eye from the side. The angle is bounded by the cornea and the iris, and it looks like a geometric angle. Where the two structures meet is the location of the natural or conventional drainage system of the eye. This illustration shows an open angle. In this magnified view of the anatomic angle, the blue Swiss cheese mesh-like structure is called the trabecular meshwork. It is the beginning of the eye's drainage system. Fluid called aqueous humor is produced in the ciliary processes, flows around the iris, into the anterior chamber, and then removed through the trabecular meshwork. Deeper in the conventional drainage system is Schlemm's canal. Think of it like a tiny circular hose which collects the fluid from the meshwork. On the other side of the tiny hose are even tinier tubules called collector channels, which drain the fluid into the venous blood system. This graphic illustrates the various angle widths and degrees. The single illustration on the left is a sketch representing an open angle. The two larger sketches on the right illustrate narrow angles of various amounts or degrees. In narrow angles, the iris is positioned closer to the cornea, potentially blocking drainage. The term narrow angle is an anatomic description and not a disease or a diagnosis of glaucoma. When the anatomic angle is narrow, like the bottom right sketch showing a 10-degree angle, the drainage system is becoming blocked, resulting in an accumulation of aqueous humor, which can lead to an increase in intraocular pressure. People with narrow angles can be completely asymptomatic. Some have intermittent and mild symptoms from subacute closure, and some have an extremely symptomatic acute angle closure crisis. This sketch illustrates the sequence of pupillary block angle closure. First, the pupillary border creates a seal within the lens. Fluid accumulates behind the iris, causing the iris to bow forward. The bowed iris then covers the drainage system, resulting in elevated eye pressure and all the other symptoms and signs. A narrow angle is further nuanced with the following terms. Primary angle closure suspect means having narrow angles without intraocular pressure elevation or optic nerve damage. Someone in this category is suspicious for, or at risk for, or could potentially develop angle closure. Everything else looks fine. Primary angle closure refers to where the angles are blocking the natural drainage system, resulting in elevated intraocular pressure, but it is early enough where there is no optic nerve damage. Primary angle closure glaucoma is where there is primary angle closure with optic nerve damage and possible visual field loss. The term primary was used multiple times. Further, there are many conditions which we describe as secondary causes of narrow angles and angle closure glaucoma. This related topic is extensive, and we will not discuss it in this presentation. Even further nuanced, there are categories of narrow angles without pupillary block, such as plateau iris, which would be content for another presentation. Let's discuss how an angle is assessed. Clinicians should maintain high suspicion, especially in hyperopic, also known as farsighted individuals, whose glasses or contact lens prescriptions can be a clue prompting targeted exams. Risk increases with age. Women are 3 to 4 times more likely to develop angle closure than men. with higher incidence in East Asian and Inuit populations. As part of the basic eye exam, a slit lamp microscope assesses the anterior chamber depth, but not the angle narrowness directly. Therefore, gonioscopy, using a special mirror, is the definitive method to visualize the angle. Advanced imaging, such as anterior segment optical coherence tomography or ultrasound biomicroscopy, offer detailed views, but require additional time, expertise, and interpretation. These are helpful, but not essential, and are less common in private practice. People with narrow angles are found in about 2 to 6% of the population, and they are at risk for acute angle closure attack, occurring in about 2 to 15 cases per 100,000 people with narrow angles annually. Therefore, this is uncommon, but it is a serious vision-threatening condition. During an attack, sudden severe eye pain, headache, blurred vision, halos around lights, red eye, and sometimes nausea and vomiting. It typically affects one eye, although both eyes are at risk. Many people will seek emergency care. Immediate treatment is often needed. Medications may stabilize the situation until an ophthalmologist assesses the patient, noting a red, fixed, mid-dilated pupil, corneal edema, glaucoma-flecken, and high intraocular pressure. Acute attacks are horrible. Subacute or chronic angle closure can occur with minimal symptoms, such as intermittent blurry vision, mild pain, or nothing. Yet they can lead to progressive optic nerve damage and irreversible vision loss. If narrow angles are identified and potentially occludable, a low-risk laser peripheral iridotomy is typically recommended. This simple procedure uses a laser to create a microscopic hole in the peripheral iris, allowing aqueous humor to flow from behind the iris into the anterior chamber with minimal complications. Some people will benefit from undergoing routine cataract surgery, which usually results in a wider angle after surgery. An acute attack requires urgent intraocular pressure reduction, achieved via anterior chamber paracentesis, which is releasing fluid, medication, this is often slower and less effective, and emergent laser peripheral iridotomy as the definitive treatment. If additional issues arise, other surgical interventions may be necessary. Usually and thankfully, only one eye is involved. However, the other eye can be at risk for an acute angle closure attack, and a prophylactic laser peripheral iridotomy is usually recommended. Let's talk about prognosis. The key is early detection of this condition with a basic eye exam, which includes gonioscopy, and, if necessary, a laser peripheral iridotomy prevents acute attacks in more than 90% of cases. However, if an attack occurs, the outcome is variable depending on the duration of the attack. The quicker the relief, the better chance for better outcomes. There is a high chance for a poor visual outcome if the acute attack is untreated for more than 72 hours. Poor vision can be from one or a combination of issues within the eye. Routine eye exams can detect narrow angles. However, the high volume of asymptomatic patients obtaining eye exams and the low prevalence of narrow angles in the general population often leads to missed opportunities for years. It requires clinicians with a high index of suspicion, keen observation, and gonioscopy expertise. Public health initiatives and presentations can promote early detection and awareness. Prophylactic treatment. Not all people with narrow angles need laser peripheral iridotomies. Treatment varies with angle severity, and this requires a personalized discussion with your eye physician. A note on medication side effects. Over-the-counter cold and allergy medications and some antidepressants and anticholinergics carry warnings to consult a doctor if you have glaucoma. This warning is relevant to people with narrow angles and not necessarily those with glaucoma, for which the open-angle glaucoma type is the overwhelming majority of glaucoma cases. These medications can dilate the pupils, which can lead to pupillary block and acute angle closure. People with narrow angles who already underwent a laser peripheral iridotomy are generally safe to use these medications. There are medications which can cause a non-pupillary block angle closure and are outside the scope of this presentation. We discussed the significance of narrow angles and how acute angle closure is preventable through keen detection and preventative intervention. For more information, reliable sources include the American Academy of Ophthalmology Guidelines on Primary Angle Closure Glaucoma. A great source of advice is by consulting a medical doctor trained in the specialty of ophthalmology and further completed a fellowship in glaucoma. The American Glaucoma Society.net website has a Find a Doctor function, as well as information on narrow angles and related glaucoma topics. Thank you for watching. Like, subscribe, and share your experiences.